Hi, my name is Chris Kansky. I'm the editor of One Business Record. We're here today to do one of our Power Roundtable series. We've done a few of these in the past, and the idea behind this is that we traditionally do power breakfasts, panels with a live audience, and before those, the idea for this, we actually were having Rob Denson and some others were in to talk before one of the events, and they said, man, this pre-event conversation that we have as we're getting ready for the event, sometimes that's the best stuff. And we said, well, what can we do to try to replicate that? And so that's our goal with these Power Roundtable series, is we're going to have you be kind of a fly on the wall to our discussion today. And today we're here to talk a little bit about the healthcare industry and some of the things that are going on in that industry and how it might affect your business. And with us today, I know we've got a great panel. We have Ed Brown, he's the CEO of the Iowa Clinic. We have Laura Jackson, she's Executive Vice President of Healthcare Innovation and Business Development at Wellmark Blue Cross Blue Shield. We have David Lind as well. He's principal at David Lind Benchmark. And Lori Wiederin, the Senior Vice President of Employee Benefits at Holmes Murphy Associates. I'm going to turn it over now to Joe Gardias. He's our reporter on healthcare and wellness. And at this point, we're not going to be addressing the camera. This is going to be your chance to be kind of that fly on the wall. So you'll see me taking notes, and we'll come back to you at the end of the conversation. So Joe, take it away.
Well, thank you all for being here today. I think we've gotten a very good, diverse group of people and viewpoints to really cover the industry. And the first thing that we wanted to start off with is sort of the big picture. What do you consider the biggest issue facing healthcare today? And Ed, I wonder if you would start us off on some thoughts that you may have.
Sure, Joe. This is going to be a familiar answer. While we've seen the passing of the Affordable Care Act, we're continuing to see an escalation of costs in the industry. And we're all working diligently to address that with some of the requirements of the Affordable Care Act. But despite some of those things, we're continuing to see a rise in the cost of health care. And I think that will resonate with your audience, and I think some of my colleagues would agree that remains a big challenge.
And what are some of the reasons behind the increase in costs? I mean, with all the attention that's been given through the Affordable Care Act and with trying to bend the cost curve, why aren't we seeing better results by this point?
Well, we continue to have an aging population out there, and that demand for health care, and you also have the catch-up factor associated with people who have not had health insurance eventually getting treatment, and the amount of resources and dollars required to get them up to speed. It remains a system as it is today where the individual self-responsibility for the healthcare dollar has probably not shifted enough to the user that it has affected their behavior so substantially that you're seeing a greater degree of engagement in trying to control their healthcare expenses and take control early on in wellness programs and things that in the long run will benefit them and reduce the overall cost. But for the time being, we're continuing to see a rise.
David, I know that you have talked about a model, sort of an upstream model for explaining what's happening with healthcare costs, and I wonder if some of that idea might be coming into play here with why we're not seeing a shift in costs yet.
Sure. I would say, and I think everyone on this panel would agree, that for the last number of years, if not decades, we have spent so much time downstream in our healthcare river trying to fight the cost component and alter our benefit plans that we offer to employers, employees. And over time, we have spent so much time on the cost component that we really have somewhat forgotten, at least some of us, about what really causes the cost problems upstream. When we have a dysfunctional healthcare delivery system, and we certainly can get into more of those components, as well as unhealthy lifestyles. And to really piggyback what Ed said about the cost issue, we actually did ask employers in 2015 about the challenges that they see within the next year, and certainly one of them would be the unpredictability of healthcare costs. The second one would be motivating employees to live healthier lifestyles in order to really make an impact downstream eventually on the true cost of care.
And Laura, from the health insurance standpoint, I know that Wellmark has a number of programs to try to reduce costs. Any thoughts on programs and their effectiveness for cost control in healthcare?
Well, so I first of all, I agree with everything that Ed and David said. So one thing that I might add to something that Ed mentioned and David mentioned, as well as lifestyles, just to put in context the chronic disease and how much the healthcare system is, the demand that's put on it to treat those chronic diseases, that's really the unstated driver of many of the costs. Because to expand on what they had said, if you go back in time and you look at what health insurance was designed for, and you played it forward to today from about 20 years ago, the chronic disease in the country is really an epidemic. We just don't treat it like one. And so what's happening is you would have about a third of the cost, or about 2/3 less of the cost of health insurance if we didn't have the chronic disease today that we did 20, 30 years ago. So imagine what your premiums would look like if we didn't have the chronic disease. Then on top of that, you have the industry creating new drugs to treat those chronic diseases. So I would imagine if I'm out with Lori and seeing a client together, we probably have the same answer right now, which the major driver, and there's still a lot of the same underlying drivers, but one of the major drivers today is specialty drug. So when you think of those chronic conditions and a lot of the specialty medicines that are coming out every day, they're anywhere from $2,500 to $20,000 to treat a patient. And a great example of that is today in our book of business, we have one person that takes a medication that costs $1 million a month. So when you think about what that does to increases for the entire pool of people in the health insurance market, we all pay that price. And that's not to say that person doesn't deserve every last piece of that drug, but it shows you what's happening with cost increases, not happening to all of us, but ultimately we pay the price. So as it relates to programs, it's really important. David's example, and I love his metaphor of the river, because you have to work inside the healthcare system to improve delivery, which I think there's a lot of great things going on with like accountable care organizations, improving quality, delivering cost of care at a lower rate. But you have to work outside the healthcare system too, which we've seen a lot of great successes with the Blue Zones communities, where they're truly changing the built environments. They're putting healthy items on their menus in their restaurants. They're targeting schools and more activity. So we should be proud as our state. We've got 15 communities in this state that are Blue Zone certified communities. They've done a lot of the hard work. They have a sustainable plan in place, and we're watching what's happening to their healthcare costs. So we hope to have a really neat story to tell in the state soon.
Just curious on the probably gets into more of an ethical debate, but you mentioned that $1 million for one drug, and I remember listening to a really well done thing on NPR about that exact topic, and just kind of went back and forth between what's the cost of a drug and what's acceptable as a cost of a drug, and that becomes a really sensitive topic. And I'm curious, you're identifying as one of the issues, so how do we have a conversation about that when really what we're talking about is it worth $1 million for this person? I don't know the answer to that, but it does seem to strike me as a tough challenge in this.
I think it's getting harder and harder every day. So, if it was the $1 million drug that was going to save me, of course, I would think it's worth it. I think in other countries, you look at things like quality adjusted life years, and that's how a lot of services and drugs are evaluated. We don't do much of that here in the United States. And, we have a free market when it comes to pharma. So if, the demand is there and the supply is available and they can raise the prices, unfortunately, that's what's happening to a large degree. And in this case, it's a very unique drug that is truly life-saving for these people every day. So to withhold it, you could never do it. And And so it is a huge dilemma and a huge debate that needs to take place in this country.
Are drug prices the real culprit, or how much of healthcare costs are drug costs contributing to the problem overall?
Joe, I'll start, and everybody else please add on, but I would say drug prices and just the overall cost used to be probably about 15% of our overall spend, 10 to 15%. They will create about almost $1 billion of the $6 billion we pay out to providers of care by the year 2020. So they're on an exponential increase, which is also what's a little bit scary, because most of these drugs that we're talking about treat a very small percentage of the population. And so small numbers of people are using vast amounts of resources.
I think you said that 50% of your drug spend will be on specialty drugs by 2020.
Yes, exactly.
I also think the United States bears a disproportionate burden of the research pharma dollar. It is a concern that you hear talked about in Congress. It will be one ultimately that we'll have to address on a national level. I think pharma sees and knows that is coming. They can hear the drums. But the reality of it is a great deal of the innovation as it relates to pharmaceuticals has occurred in the United States. Now you're seeing consolidation where the European and U.S. companies are merging together. But the checks and balances for pharma within our borders is, let's just say we've not used some of our competitive leverage within pharma to control that.
Joe, the only thing I would kind of add to kind of the healthcare industry is, I agree with everybody here. When we have a great healthcare system, we have more of a health crisis with the amount of people overweight, obese. But then another driver on the cost side has always been cuts to Medicare. We've always shifted to people with private insurance, and that's becoming unsustainable. And so now you're starting to see different payment models, and we'll kind of talk about that with the accountable care organizations. But what that will do is start focusing more on prevention than just treatment like we've done in the past.
And speaking of accountable care organizations, I really wanted to see if we could get a sense of where things stand with accountable care organizations. I mean, they just rolled out, it seems like just maybe a couple of years ago, but maybe it's been 4 years now since they've really gotten going. And I know that Wellmark is deeply involved in several of those efforts. That we could talk about how far along ACOs are and what they really are starting to accomplish. What sort of momentum are we seeing, perhaps?
And I would probably say, there's different models with the ACO. You have the attribution models, and we're starting to see some claim savings, maybe around 2%. But then when you get into the product ACOs, where the employee knows that they're going to go to a certain provider, you're going to see a bigger cost savings. And then, now we're going to see in 2017, when you start to see joint ventures between a hospital system and an insurance company, I would think you'd see even bigger savings. But we haven't had that yet in our marketplace.
So, in practical terms, what are people seeing? I mean, is the average person who's covered through their employer now hearing about ACOs? I guess I haven't personally, but maybe if you're in a larger organization, you're hearing that term and experiencing ACOs a little bit more.
I would say, here in Iowa, more what's been in place is the attribution model. So the employees really haven't been aware of it, but now there's starting to be more products out there that are product ACO that will drive them. And so that communication has to take place. but they're not as prevalent as they are probably in some other parts of the country right now. I don't know if you agree with that, but.
I would say, once you've seen the Accountable Care Organization, ACO, you've seen one
Yes.
ACO. They are all birthed through different coordinations of care, depending on how that community is structured, depending on how the physicians and hospital systems work together. I mean, we have certainly worked within the Accountable Care Organization structure as a multi-specialty clinic. And while we do not have a hospital, that doesn't mean we don't collaborate, coordinate, and contract with a hospital and other services to deliver what we consider an organized delivery system. There are other systems out there that are fully integrated and want to have as much as they can within their structure. I think quite honestly, I think the jury is still out on the effectiveness of the model this time, because what's key to it is how well you can coordinate and deliver a more efficient form of health care within the system you have. There is such a thing as being too big in order to be adaptable to the changes necessary to get efficient. So there are stories throughout the United States of people just doing a terrific job moving the needle, and there's some who are keeping it the same, and frankly some that are going back.
I would say, I would say on a national basis, based on the literature that is out there, and believe me, ACOs are being scrutinized as we speak, which models seem to be working, and it's really mixed as far as the outcomes on various models. And one concern that I have, and I'm glad Ed is here to maybe provide a little bit more insight, is in an ACO you have various providers, you have hospitals, you have physician groups, you have various players within a particular model. And my concern would be making sure that the cultures of those organizations are aligned to coordinate the care, because in essence, these organizations have their own culture, and it may or may not align with what this ACO is attempting to do going forward. Now, I know it sounds like, okay, well, let's just put together an organization and let's make it run, and we'll coordinate care, but it goes beyond that, I believe, and I would be curious, maybe for Laura or Ed's viewpoint on how you see that meshing together over time.
I'm trying to remember who I'm going to quote here, but there's a quote out there: strategy is critical, culture is everything.
Yeah.
And it may have been Jack Welch, but I agree with you in regards to culture. We're a physician-owned, physician-governed organization, and as it relates to what the most powerful thing is within our organization, it's this pen. And how the physicians within the organization understand the most cost-effective way to use it in the delivery of the care, and they are all moving in as much of a synchronized business fashion that makes sense for them. You do have conflicting dynamics that occur within some integrated organizations, because you have incentives to try to be cost effective that, on the other hand, may cause a reduction in revenue, and you have to keep those things in balance, that while in the short term there might be a loss of income that occurs, in the long run you're going to be further ahead in reducing the overall premium cost, but also improving the cost of care of that patient, and you'll be better ahead. You'll be better off for it. Those dynamics are out there. I've lived that almost my entire career, not just within the Iowa clinic, but also within managed care organizations. You have to step up and be able to address that right up front, and the organization organization has to make that cultural shift to accept the risk associated with this change.
It's okay, Joe, I would probably add to that. So we have a total of 15 accountable care organizations that we have contracted today in 16. And like Ed said, if you've seen one, you've seen one. They all perform very differently, and I do believe what David said is true. It's because of the culture of the organization and how they can really systematize what they need to do to get done and coordinate the care. And it's how they treat one another, and it's how they behave. That said, I would also offer that I don't think accountable care organizations are an end state, they're a stepping stone. And a lot of times people believe that that's the holy grail. Accountable care organizations are really a step because fee-for-service is still intact. And to Ed's point, then you have this trade-off of if I do something short-term to take away compensation, maybe if I know how to play the long game. So if the organization doesn't understand that, they won't be successful in accountable care organizations. So when you look at the organizations, I think that will be successful in what Ed just described in the long game. It's whether or not they have really a provider-led organization, whether they can take the data in, they can make sense of it, and they truly can understand how best to give care to a population. And it isn't just when they walk through their door, it's that continuous outreach, it's the prevention, it's the chronic conditions, it's that active management of the patient. And so when we look at all of them, like I said, they're all created differently, they all perform differently. And I'll give Mr. Brown a little plug here. So the Iowa Clinic is, last I checked, they were the best performing ACO that we have in our book today, both in cost and quality. Because I would tell you that what David said is true, their culture is set up so that they do play the long game. They know that eventually they could create a product, to Lori's point. And if they had a product out there, they would be the lowest cost, highest quality, which ultimately gets you market share. So it's a long-term game that I think organizations need to understand how to play. But the good news is, even in what I call this practice round of 15 ACOs, we've seen an aggregate about a 35% improvement in quality across all of them, so without singling anyone out. So there is forward momentum, but there are things out of, let's say, Ed's physician's hands in this example. So if they write a script and the script goes up by 20% tomorrow, that ultimately impacts them. They can't control pharma costs. So we try very hard to show them all the different drivers of care so they can control what they can control, and then they need to understand what they can't control. So it's a work in progress is the way I would describe it.
I would add to that, though, in order to be successful, you have to be willing to invest in the necessary tools and develop the necessary partnerships to get people focused on those target areas. I'll brag on our partnership with Drake University School of Pharmacy to focus on high-cost pharmaceuticals. We have a PharmD who sits down with both our physicians as well as those chronic high-cost patients that use a lot of pharmacological treatments, and we try to look for other options that make sense and still have the same efficacy outcome. That it's just a matter of educating and coaching and say there are options here, and there's some more cost-effective options. But you got to have the data. You got to get the data out. You got to take the time to sit down and educate. That requires resources. That requires a lot of time.
That's why I think it can be a great marriage between insurance companies and providers, because insurance companies have all that data that they can really look at, stratifying that risk and bringing really the risk management resources to the providers, and the providers have the clinical resources that, in the end, it can be a great partnership.
And that's in fact what we try to do with the 15 ACOs is bring all of that information in the dashboard and let the provider organizations have at it. It's all risk adjusted. Lists are created for gaps in care, and then Ed or whomever else, their organization can decide how they want to attack the issue. And they think that the next generation, which is going to be interesting, so we, over the last couple of years, have done a self-funded pilot where Wellmark basically flipped the bill for the shared savings, if there was any, and had 10 of our largest employers participate in understanding how it all works. And it's been interesting for them to really challenge the providers. We've had some of the physicians come in and explain what they do, and the employers will literally say, why would I pay you to do X? And so they had to kind of make their case. So it's been a really interesting dialogue to have the carrier, the employer, and really the provider organization in order to have that conversation, because that's how I think we're gonna actually change the cost curve.
Laura, while we're still on the ACO, and Joe, to your point, how critical is it for your members to know whether or not they are in an ACO?
Today, I would say that it's not as critical, and the reason I say that is we've been trying to give the providers an opportunity to understand the data, garner the resources, and literally put a plan in place to improve the way care is delivered. At some point in the very near future, I think it's critically important, because what we found, especially in the state of Iowa, people like choice. If I'm downtown and I want to go to a physician, I don't care where I go. If I'm sick when I'm not feeling well at home, I want to maybe have the convenience to go here. That makes the physician's job very difficult to coordinate care when I'm kind of fickle in terms of where I go.
Right.
So over time, you do want to create that accountability. Ironically enough, when we started the ACOs, we made the offer to the first 3. Would you like us to create a product around this? And guess what they said? No, don't do that yet. And so we didn't, because we thought truly they would want that declaration of, yes, I'm coming to see Dr. Lynn. And they really didn't want us to start there. So we didn't.
So when we talk about the value of data, I wanted to ask about electronic health records, and I guess I've heard stories secondhand that doctors aren't the biggest fans of electronic health records, and that they're difficult. They can be difficult to transition to. But I wonder what sort of progress has been made with electronic health records, and is that making big improvement in the quality of the data and availability of the data for health providers?
I guess that's teed up for me.
We can drink water.
Yeah,
We, I would say when the health record movement began to occur, we were in the infantile stage, and I would say we're in the adolescent stage now. There's also a generational factor associated with this. You would never have a physician coming out of schooling today or residency today and not expect to work with an electronic health record, and they don't even think twice about it. And it's like driving an automobile versus riding a horse. We had a lot of people riding horses, and the young kids today, they just they go to it quickly. That said, we are looking for different ways to improve the record. And what's interestingly changing is while the health record was supposed to be the answer to a lot of things about efficiencies, it is becoming a reality that the data information that you get out of that and your ability to mine that data is as much important as the record itself. There are ways that we're looking to make our records more efficient, certainly through technological upgrades, attaching products that are best of class that help provide us information. And interestingly enough, we are moving to systems whereby new jobs are going to end up being created to help make, and I think they're short-term jobs, to make physicians more efficient, where we're putting scribes actually as part of the physician team, so the physician can work more efficiently and have that eye-to-eye contact instead of sitting there putting data into the computer for the medical record. So I would still describe the EMR, electronic health record, as it's in evolution, and it's gone through a state of revolution where people have been frustrated with it, and every organization's at a different phase.
You said that I was reading a story about the Internet of Things, right? And the idea of that in a potential future you'd be able to monitor. So you've got a heart, you've got a pacemaker, and it might be going into to the doctor's database, and it comes up and someone's heart rate has been off the chart, and it's showing signs that they're.
That's already here.
Yeah.
You'll see that, and you'll see much more of an embracing of that. In fact, I would predict at some point, it may be a decade from now, maybe sooner, that there'll be some very bright young man or woman who's going to figure out how to put this all in the cloud and all the systems that we use today will be irrelevant, and we will be mining data that will be common data among everybody. And you'll find these little iPhones that sit in our pocket will be much more powerful and used as a part of our health than what we think of them today. So technology is going to have a dramatic impact on healthcare, and it will occur rapidly.
Imagine that if you can use that on the preventative side of it too, so not just that, oh, you are sick now, but that you're showing the signs of then
Very much so.
and maybe to the cost of that, and maybe we could address that, but if you're able to catch it at the front end as opposed to later on, how
We
much
should show back up in the beginning. I mean, that really is the ultimate goal.
Yeah, we have care coordinators in place that track our chronically ill patients, and some of our colleagues out there are putting technologies in the home, whereas we expect, say, somebody with congestive heart failure gets on a scale on a daily basis, it reports their weight. If their weight changes more than a pound, they get a telephone call and say, Mrs. Jones, we've noticed your weight's gone up dramatically overnight. Tell me what you had for supper. And, you know, and what we're trying to do is catch that risk of that congestive heart failure moment that would require an acute emergency room admission. And we can get that on the front end, treat it, and say, Mrs. Jones, no more pizza and beer at 9 o'clock at night. So you know, it's a matter of becoming more proactive, and technology is going to do that more and more for us.
How has technology been advancing in the health insurance arena? I mean, I know that the new diagnostic codes that just been rolled out with not.
All 85,000 of them.
Were there a few funny ones that, like, I mean,
There are.
There are.
pretty
yeah.
shocking ones if I remember.
Yeah.
Like water skis catching on fire.
That's a real one.
There's some pretty
So-
interesting
There are
ones.
some good ones out there.
You wonder who made these up, don't you?
Yeah, you do, don't you?
But just wondering if there have been some big renovations or innovations in health insurance that you're seeing that will make a difference in the next few years.
I don't know, technology in health insurance, right or wrong, moves pretty slowly, and in large part, it's because if you think about what a health insurer was created for many years ago, it was to really take in a claim and then pay the provider and make sure that we accounted for the dollars. So it's really more of a billing institution, if you will, and then managing the risk of that population so that you could price right the next year. So, you know, legacy systems in most health insurers were focused on just, hey, the claim came in from Laura, and so let's put that claim in the basket. So as we've evolved and really tried to be more customer-centric and put a whole picture together of a patient, that has really put a lot of pressure on the industry. So that's where you see a lot of the venture capitalists, a lot of the Silicon Valley bringing new ideas to the table. One of the things that we have embarked in, and which is sometimes the fate of a company in positive or negative, we are putting in a brand new claim system so that we can be more efficient and more nimble and actually bring those innovations to the market. So we're in year 2 of a 4-year migration to a new claim system. Will the general customer see that? Probably not. Will we see it in efficiency? We better, absolutely. So once we're there, then we have the ability to bolt on a lot more, what I'm going to call the innovative technology that can be more consumer-facing, the transparency tools that shows not only how much something costs if I go to Dr. A versus Dr. B, but also, you know, importing their cost and quality information, which we can do some of today. In addition to that, it can show them then where they're at in their benefit accumulation. Am I at my out-of-pocket maximum? Am I just, you know, am I going to have a cost share? So it's really about making this more patient-centered or customer-centered. And so that's really all of our technology is really revolving around all of that. Some of the challenges, however, is redesigning every piece of communication that goes out to a member. So for example, this might sound like I'm whining, I'm certainly not trying to, but just even comply with the Affordable Care Act to be a qualified health plan on the exchange. In 2017, every insurer has to make sure that every piece of communication, website, letters, IVRs, customer service reps, what they actually say, has to be compliant with accessibility standards, meaning that if you say, I'd like that piece of collateral in Braille, we have to put it into Braille. If you say, I have to have a screen reader to read everything on your website, everything on our website has to be compliant with a screen reader. The cost of that for every insurer in this country is very, very large. And so there's a lot of underlying costs and work going on in the technology space, just really to bring us up to par with many industries. So I'm not whining, it's just an is.
It's okay.
Yeah,
Is it? Okay.
we're all
We're all
going
in
to do
that
that,
boat.
right? Telemedicine, telehealth.
I would say telehealth.
Yes, Medicare is a laggard when it comes to reimbursement for telemedicine. In fact, I just read something recently, it's just astounding. In 2015, I think Medicare pays out $650 billion a year, but only 17.5 million of it was telemedicine. And how do you see telemedicine or telehealth in Iowa with the reimbursement for providers? Performing that for rural
Yes.
individuals, because I think that would be a big issue. And,
Yeah.
you know, Ed, I don't know how you're seeing it from your end.
I think Medicare is fantastic in regulation and a little struggling in innovation. But that being said, as you see providers take on affordable risk as the premium dollar proportionate to what they can afford, as they take that on, that will move providers to move to telemedicine, which will probably be more efficient than what we have today. It's hard for the payment system with providers today to live in two worlds. Right now, that's what we're living. And we say to ourselves all the time, if it works in the current fee-for-service world and works in the managed care world, we should absolutely do it. If it works strictly in the managed care world, we have to ask ourselves about the capital outlay, if we can afford to do that in order to be innovative, get that in place now, till such a time the payment system changes. So the whole migration to a different delivery system that's been outlined out there for us is a very heavy lift. And unless it's done correctly, it will be very difficult for some people in the healthcare delivery side of the world to be able to sustain themselves economically. They need to be very thoughtful about it. Risk, there's a reason they call it risk. Not everybody's out there to do it, and they better have tools in place in order to step into that venue. So,
I think, and telehealth, I think, is a great example of true innovation. And we have walked into it very softly and carefully, saying basically, instead of national models where they have providers that come into your market that basically subordinate what we just talked about, which is pick your doctor, go see your doctor. And if a national model won't feed that data back to your physician, then what have you really done to giving them the ability to manage a population, if you will? So we've really waited for our local providers in both states to literally say, we're ready to do telemedicine versus letting those national competitors come in ultimately and drive up fee for service, because they have no markers to say, if I deliver a telehealth visit to you tonight, I have no reason to believe that you won't go see your physician tomorrow and you pay twice.
I think that's
So we've been
Medicare's
very, yes,
concern,
and we've been very cautious about that. So the good news is we do have a vendor now that we're implementing, but it is about creating a local network of doctors, so it's not a national doctor somewhere, someplace in the country. And they do have the ability to literally say, if someone is seen in, whatever the rule you want to make up, let's say it's within 3 days for the same diagnosis, maybe the compensation isn't there for both visits. So we want to be very mindful that it keeps costs at a reasonable rate. It's actually delivered at a lower cost. It isn't just driving up the total cost of care.
One of the challenges with cost too is that you're rational about your own health, right? So you're feeling sick, and so if I can just call somebody out,
Right.
call somebody or video chat in with somebody, I can see how that could cause.
Well, and it's
actually
interesting that it's been the concern, but I will tell you, some of the customers that we have that put telehealth in place even 2-3 years ago, they do not get the uptake. So as much as you'd like to think that everybody is clamoring for it,
Still wanna
it
go
is
see the
amazing.
doctor.
They still want to go see the doctor and have the conversation.
I think it all depends, a lot of plans, if they have the high deductible health plans
Yeah.
and there's more consumerism involved, you're going to see a greater uptick in the telehealth. And then also, I think with the innovation, there's more the member engagement tools and the transparency tools that help out, especially with people with
When they have time to shop, yeah.
I think another confusing aspect of the whole telemedicine aspect of things is we have reasonably good access to primary care in Iowa. Other urban areas, that it's a whole different story there. So you see, it's much quicker uptake in that. I know people who have electronic or e-visit programs in place, and they're only getting 3 or 4 calls a day. And they've spent millions invested in this. It becomes an issue of timing. I'll say the other thing too is Iowans, at least based on our survey results, if they have their druthers between electronic and face-to-face, if you provide access, they will take face-to-face.
So do you see, I think I read somewhere that the number of people that go into medical school, only 2% go into the primary care field because people are going into the specialist. But do you see with ACOs, do you see that changing because the primary care might direct more care?
I think.
You'd have to still pay them more.
Yeah.
But people
I
went to the
think
specialty
the
because they have
dilemma,
more.
some people do, okay, there's no doubt about that. And why are they going into those subspecialty areas? It's because of the cost of medical school. It's not uncommon for people to come out with $250,000, $300,000 debts. And they honestly wonder to themselves, how can I ever afford to pay that back? And based on primary care income, that becomes a push. There are things being put in place, whether it's incentive bonuses or tuition payback incentives, things of that nature that are incentivizing physicians to go into that primary care field. And I don't see those going away, quite honestly. But I would also say that at least here in Iowa, I think our biggest encumbrance is we're going to have a pretty dramatic reduction in primary care over the next 10 years, merely due to retirement. And it's not that people still aren't going into primary care, it's just they're going to be retiring faster than what they're coming out.
It's true of a lot of professionals in the entire healthcare system. So whether it's the physicians,
Mhm.
the hospital CEOs, the agents that sell the
What are you
products.
saying?
I said hospital CEOs, not especially clinics.
You're
No,
exempt.
you promised all of us you'd stick around for a long time.
Well, it is interesting though when you think about that primary care doctor. My wife was just sick recently. We went in and had a different doctor at different times, and he couldn't see what the first doctor is saying. It's just a simple example like that. It's a very small scale, but the cost in the grand scheme is big.
Right.
I can imagine translating that out over time.
I don't think there's any doubt you're going to see advanced practitioners, whether it be nurse practitioners and PAs, being a bigger part of our healthcare delivery system, and people practicing up to the maximum level of their licensure, where those acute colds and sniffles and things of that nature will be taken care of at that level. The more serious illnesses being transferred to that primary care physician to evaluate. And hopefully there is a connectivity to that specialty care that then gets quickly moved on to that as appropriate as well.
So now that we've been under the Affordable Care Act for probably 5 years or so now, I mean, I wonder what sort of consensus is coming about from professionals like yourselves. Where have been the biggest positives with it? Where have been some of the biggest negatives? And what are the biggest fears ahead for it in the next few years?
I would say, the positives of the Affordable Care Act is, one now, if somebody has pre-existing condition, they have access to care. and I never thought I would be saying this back in 2010 when this was passed, but I do also think that it has pushed the market to emphasize more on outcomes and value than versus volume.
It created ACOs.
It created the ACOs, which I think in the long run will be good because it will focus more on prevention than treatment. But then the bad side, it hasn't done much to reduce cost. And employers have seen increase in taxes or fees that they're paying. And then that doesn't even count all the administrative work that has been put on the employer, the insurance companies, the physicians. There's just a lot of administrative duties.
You just go right down the line on that question, just positive
On
and
the good and the
negatives.
bad?
I think
Yeah.
it'd be interesting to hear what your guys' thoughts are.
Yeah, so I agree with everything Lori said. I think some other positives were, in this state, we had age 25, or at least we did at Wellmark, but you could keep it dependent on your policy until age 25, which the ACA expanded to 26, which is good. I think some other positives would be not only guaranteed issue, but also guaranteed availability. So if there's a product out there and someone wants to buy it, you have to sell it to them. You can't cherry pick. So I think that was good. I think the prevention in terms of the essential health benefits and prevention covered at really zero cost share, I think that's definitely a plus. And the subsidies for people who truly need help with affording health insurance, I think is also key. I think that the difficulty with all of this is what Lori said, it's the taxes and fees across all segments, including employers. And then when you layer all of that on, the regulations that are required to comply with the Affordable Care Act become very, very large. And when you look at just the individual market and look at the rate increases you're seeing really around the country, at least in this state, what I can say for certain is what you've basically done is taking a pool of folks that had insurance, a group of people who didn't have insurance, and folks from the high-risk pool, and you're putting them all together. And there's pent-up demand, like I think Ed, you said that earlier. So you have pent-up demand. You have folks entering and maybe not knowing exactly how to use insurance, and using it in a way that they need it. So that's the good part, that they actually can get access to it. But it is driving up costs at really exponential rates, and we don't see that really flattening out for another couple of years at best. You had the risk adjustment, the risk orders, and the reinsurance there. Two of those risk programs go away in 17. So all you have left is risk adjustment. So the other thing that it does in the individual market is it puts insurers in a situation where you can lose a ton of money and you can make very little. And so it becomes a very, very slim margin. You have to be really good at actuarial science, because in the individual market, you literally have to look at all of your risk from a year ago, and then you have to play those rates forward 2 years. And so we're setting rates for 17 based on 15's data, and we will file in April. And I'm not sure if you guys have ever tried to predict things, but predicting healthcare costs is really difficult when you see what's happening. So that in and of itself makes it very difficult for an insurer to understand what's going to happen, how to price their products, and then you cross your fingers once your rates are out there.
Because your whole risk can be totally different.
It can be
than what you have in
completely
2015.
different, because I can come in and out of the products whenever I want to, which again is good for the individual, hard for the risk pool. We have special enrollments. If you look around the country, that is costing health insurers millions and sometimes billions of dollars. And so it's really not even the fact that there's exchange business that's risky, it's the entire individual market. So we're looking at how are we going to do business in that individual market very differently with new products. Like Lori said earlier, partnerships with provider organizations to really deliver care differently, because I'm afraid at some point many carriers won't provide insurance in the individual market if they can at least keep their head above water.
Gone under.
And I think most could have predicted that, because you can't underprice your products, because then you have to manufacture money, and last I checked that was illegal.
So is it fair to say that the health insurance industry is becoming less competitive under affordable care?
It's not less competitive. I think there's, especially like I said, in the individual market and even small group, when you have the risk adjustment, it puts a ceiling on how much you can make, because you have to rebate it back, but it puts no downside on how much you can lose. So your precision and really where you want to offer products becomes a selection. And then all of a sudden, you ask yourself, am I really providing health care to the individual, or health insurance to the individual market?
Well, even have some of your competitors ask themselves the question of whether they want to remain on the exchanges because of the amount of losses that are occurring. And that, with all the consolidation that's going on, that begs the question whether the entire system even has a chance of succeeding.
I would agree. I think every carrier is really evaluating whether they're going to be in that individual market.
I think.
For the record, our plans are to stay in, so just
Okay.
understand.
Can
We're
we
trying
get-
to find
can
the
we
right
get
way to
that
do
right?
it. Yes, sure, my pleasure.
I would say that in addition to covering more Americans, the whole premise of the ACA was to spur new healthcare delivery models, and that's what's happening today. I think we have the Wild West occurring today
That's a great
in a different format where providers and carriers are joining forces and collaborating, which is actually a very, very good thing. Defining what the quality measures may look like, which we sorely need. In order for consumers to better understand the associated costs and the benefits of the care that they're seeking, especially with continuing healthcare costs moving upward. More and more people have high deductible health plans, and so they're trying to discern, well, how do I spend this money because it's coming out of my pocket, and I need to understand that if I go to this particular provider, I will get this type of care at this cost. And we're not quite there yet. We're still working on it. And I know that there are a number of examples out there. But the big picture is I think the ACA has allowed this national discussion to occur. Now that we can really begin to understand, okay, costs are one side of it, but we also need to look at the quality portion of it. And how do we get there? And I think sometimes the population tends to be a little bit passive about really pushing a little bit more and understanding what's happening in the marketplace within healthcare itself, really relying on the provider community, the insurance carriers, employers, to make the decisions on their behalf. And I think the population needs to be more engaged, and the only way to do that is we need to go through this discussion as well as the disruption that is occurring. Having said that, we are in a political quagmire when it comes to the ACA. Just look at the presidential elections.
I hope I don't want to.
Yeah, and now we're beginning to have the discussion about a single payer system versus what we have today. And do we have a true market system in place today within our healthcare? We don't. We have both a public and a private partnership. And there are many that will say, well, the marketplace has not been really allowed to succeed, and I would probably be in that camp. But we're having the discussion, and in that regard, I think the ACA is, that's part of the dust settling. And we continue that dialogue moving on. And I think it's long overdue.
I agree, David.
I guess my comments would be on the good side, we've improved access, both from an insurance standpoint as well as from a provider standpoint. I would say we've improved the focus on quality. It's first and foremost in virtually every business discussion that we're having at our clinic, and how we can better deliver care and treat chronic conditions. And the intensity of that discussion would not have taken place without the advent of some dramatic legislation that brought it to the forefront. I think from the, I'll say the bad side of things is we've got a public out there that's trying to figure out how to access healthcare and buy on the exchange, and they're not fully understanding the products they're buying, and they're buying these high deductible products that they get into, and they don't necessarily understand what their obligation is here in this product. They think they have insurance, and we have a fair number of people that come in, and we have to explain it to them and educate them that you're going to need to pay this now in order to cover some of the expenses of this, and they don't have the resources for that, and they were under the perception that those resources were covered in their coverage. And that's a much greater number of people than we realize out there. The ugly to the Affordable Care Act, moving down the continuum, is the burden on us as it relates to the regulations and the expense and the demands to put all this in place is quite overwhelming. I don't know how the smaller groups out there are going to deal with it. That burden has also turned around and produced a counter economic effect in the industry, and that is the development of oligopic economics. You have all these systems all over the country merging together, and the big get bigger and get bigger, and there is a presumption they're going to get better, and that's not necessarily the case. And they're going to get more efficient, and that's not necessarily the case. And there's a presumption that if I get so big, I don't have to worry as much about the economics, but we've seen another 2008, you can be too big to fail, and but you can fail. So it is, we've created some things that, as a consequence of the ACA, that we don't fully understand the implications of them, but I don't think they were what was intended to come out of it.
So, do you think if, both on that, the burden of the regulations, and also the kind of bulge, if you will, on the people utilizing it for the first time, is that part of the is that going to be part of the process? At some point, do you get through this transitional phase, and some of the burdens from the regulation eventually come down and trying to work your way and figure out through these challenges, and at some point you're past that, or is this or the regulations and those type of things, the cost from that going to continue on down the line?
I don't know, from an insurance standpoint, I mean, if you look at the global simplicity index, health insurance is like one of the most difficult things to understand, and we're always looking at how do we make that complex simple, but it's just a difficult business for people to understand how to make their plans work, and we've been having that issue for many years, and so I'm not quite seeing how we're putting more engagement tools out there, more consumerism tools, but it's still a difficult process.
We actually, kind of going back to the innovation question, it's not technology related, but to that end, Lori, one of the things we've done is we hired this last year a behavioral economics company to come in and help us think through how do you simplify a benefit design to engage the consumer to understand cost without creating another transparency tool, and really put them in the driver's seat so that it's very intuitive. They can't make a bad decision, because that's the whole idea behind using behavioral economics, and really put them in a situation where they're nudged into the right choices. So our hope is that we can bring a new product to the market that will simplify that, so there is no math that's required, so you don't have to calculate a co-insurance. You can literally be in a situation where we hope we don't drive up bad debt for Mr. Brown, because when the providers have more bad debt, that puts pressure on the payment system, and somebody ends up paying for it when someone else doesn't. So I think simplicity is going to be key in the individual market to let these regulations settle in. I think being very, very cautious yet optimistic about how you price the products. Eventually it'll settle down. The question is really when, and how often you can let people churn through the system with special enrollments.
And it's very cyclical too. I mean,
It
the
is.
insurance industry, and again, I think we're all operating in a dark room. We can't see anything in front of us, and we're desperately searching for a light switch to turn on, and maybe some of this might have a flashlight. But it's very difficult, and to answer your question, not with an answer, but I think roughly about 17 million Americans have been covered since the end of 2015 due to the ACA, but we still have about 30 million Americans that are not. And so if indeed we're able to see that bulge of maybe the usage drops after people have been covered for a while, we still have those that are uninsured. Somehow, we're trying to get them into the market as well. And that can be a real tough thing to do, with the incentives that are being offered, and that remains to be seen.
I think also that, addressing some of those things, some of the, and I'll brag on Wellmark a little bit here, reaching out to the providers and connecting closer to the providers so that as a consequence of that connectivity and seeking out greater efficiencies in the system, writing different innovative product out there is more possible. And I agree completely with Laura that if we can allow those innovations to occur within the system, and we have the tools within the system to make them effective, I'm talking about technology, I think we can achieve a lot of the hurdles that I'm talking about here. At the same time, I've not seen many bureaucrats come to me and say, we need to get rid of some of these regulations. Once they get put in place, it's hard to pull back. And, there'll have to be some pretty substantial sweeping changes in order for that to occur.
I'm just curious, as we've talked a lot about some of the underlying reasons for the cost and some of the things that you guys are all doing to work on those challenges. Coming back from the business side, if I'm offering health insurance, what can businesses be expecting in terms of the next few years here down the line?
I do think one of the things that employers can do to help control cost is more and more employers are getting involved in engaging their employees on clinical improvement. We've always used the term wellness in the past, but buying a fitness club membership only worked for people who were working out already. So we're really looking at the clinical improvement. And the ACA law does allow for a bigger penalty, so to speak, to be on employees that are not being engaging in clinical improvement. So I do think that employers can help in that regard in the long-term controlling cost.
Is it, I was wondering if it's fusion, right? So you're going to have to help me out and understand for a second, but right now, each individual business, the health of their business doesn't impact their particular rates.
It does if they're larger. Small group and groups under 50, it does not. But larger groups, it is based off their claims experience. So if they can improve the health, they're going to improve their cost of their rates.
So
But culturally,
yeah, if you're the under 50 business, and you're saying, which a lot of businesses are, what's the benefit for me offering them? It's a good thing to offer.
We've had that exact
Absolutely,
question. Yeah. So why can't I see that?
If I'm not thinking holistically, right, and
Yeah.
I'm thinking, well, why am I offering help? Yeah.
that's
Is that part of
a
the
great question. Unfortunately, for groups under 50, they're based off of age, their family makeup, their geographic location, and whether they smoke. Now, whether they do any type of wellness or clinical improvement, it's just going to help the productivity of the person, but they're not going to see it in their rates.
Unless the whole lack of smoking.
Right. Everybody, yeah.
I think, Chris, your question was about where do we, what's going to happen in the next few years with costs, and again, I will plead ignorant.
In the
on
dark,
that,
right?
In the dark, we're all in the dark here, but put a blindfold on me, turn me around 10 times to the left, 10 times to the right, hand me a bow and arrow, and ask me to split the apple on top of your head 100 feet away. I'll try my best. And basically my best.
That sounded like an impressive story.
And this story's going somewhere, right?
It's the new healthcare model.
That's
It's the new
right.
healthcare
Oh, gosh,
model.
we're in trouble.
I can tell you what I do know. And again, we have the political environment. We have the new delivery models that we're constantly working on. Whether they will be successful, from now and in the next 5 years, and we'll see what happens from all of that. But there are a host of issues that affect what the cost truly will be. And we can look back, however, and look back at the 5 years prior to the ACA, which it was passed in 2010. And the average Iowa employer reported that they received annually about a 10.3% increase before they made plan changes. When they made plan changes, the actual increase averaged out to about 6.5% annually. That was the 5 years prior to 2010. Since 2010, the average employer in Iowa reported an 8% adjustment on their rates annually. And then from the plan design changes, it went down to about 4%. I would look maybe in the next 5 years, because we still are living in a world of uncertainty regarding healthcare costs and the drivers and where is all of this going. I would expect that the employers in the next 5 years will probably see in the upper single digit increases, maybe low double digit, but it's really hard to say. Casting back the last 5 or 6 years, and that would really take employers to have a net effect of somewhere between 4 and 6% increases on an annual basis. But again, this is just a guess. This would take the premium that employers pay in Iowa by 2021 to about $8,700 single, and about 23,000 family in 2021. The CBO just came out with their report last week, and they indicated by the year 2025, employers can expect their rates to go up by 60%. And so...
And they're usually conservative.
And they're conservative, exactly. So I think we're going to be seeing more of the same when it comes to healthcare costs, because we have not yet slayed that dragon. And it's taken us decades to get us to this point, and it will take us a long time for us to work ourselves out of this.
The concern is that, in the past, employers were able to make plan design changes, and now you're, kind of looking at out-of-pocket maximums, that there's limits on that. You only can go up so high, and some employers are already there. So they cannot make as many changes as they have in the past.
Exactly.
And there's a theory behind that will provide the issue of consumers and technology.
It's a fine balance.
Yeah, it is a fine balance. I don't
At
know
some
if
point,
that
it's not
would be
insurance
changed.
anymore.
Yes,
Right.
I would agree with that completely.
Say-
You start moving more, more looking like some of the dental insurance out there, that basically your coverage will be for catastrophic, and you'll be finding the most efficient ways to get some of the more acute things done for you.
Or pass them off again.
We are best to skip.
Do you see, with health insurance, do you see small and large group coverage costs moving a little bit closer, perhaps, where it's a little bit more, perhaps a little bit more affordable for the small groups under the Affordable Care Act, or with the changes that we've seen? There's always been a pretty big disparity in the advantage that large groups have over small groups. I'm just wondering if there's been any movement in that regard.
And I know that question was, for me, was the small group. Some small groups actually saw decreases in their premiums because now it's community rated, so it's based off the age of their population. So if their workforce is a younger workforce, they actually saw decreases. The other part of it with the small group is they have all the mandates, they have all the health insurance fees and taxes, where a large employer who's self-funded might not have all those additional fees. So that's the one value to large groups. But again, small groups, it all depended on your workforce, whether you saw increases or decreases.
What we've seen in our past studies, Joe, is that smaller employers tend to get hit with higher increases than their larger counterparts. And interestingly, their premiums are not that much greater than the larger employers, but where the smaller employer really shines would be in what they're asking their employees to pay through deductibles and out-of-pockets. They're considerably higher than the larger employers, because the employers are constantly looking for ways to keep their costs down through cost shifting.
When we talked about it, we did an HR roundtable, we talked about it just popped up briefly, but the talk about whether employers would continue to have, to offer plans and whether we start seeing a shift at some point. I'm curious what your guys' thoughts are on where that might shift in the future.
You know, I still see it staying with the employer. We did modeling for all of our clients, whether they got out of the game and paid the penalties versus staying in the game. And for the majority of the employers, it's better for them to stay in the game. They could offer the bronze level plan and charge the maximum allowable. And that would actually cost them less than paying the penalties because that's not a tax deductible expense. And then if you really think about it, employers never had to offer insurance in the past, but they did it as a recruiting and a retention tool. That hasn't gone away.
I would agree with that. When you have 3% unemployment, particularly in Iowa, it's pretty attractive to want to keep it in order to draw from employers.
So right now, if I'm a business and I'm not offering insurance, I have to pay the penalty. Is that the
Correct.
costs are going dramatically higher though? And would it at some point?
At some point, you might reach a tipping point. I think it just
Yeah.
depends on how some of the taxes and fees
Yeah.
and mandates tip it, like what Lori said, the modeling that they did for their clients. So for some it could, but they talked nationally about a lot of employers that are going to dump, their employees into the open market. And we just simply didn't see that here in Iowa.
Yeah, that is just not been the
We
case.
really only saw what we call the micro groups evaluate that option. So maybe on 3 or 4 people tops. Do I look at an individual policy for each person, or do I keep my small group status? But our average small group is around 7 or 8 people. And those groups, there's over 10,000 of them here in Iowa. And they've maintained their status.
The only groups that might consider, you take a nonprofit where some of their employees actually might potentially be better off in exchange and get a subsidy, and then they don't have the tax advantages like a privately owned company or for-profit company.
I think we've asked employers within the last 1 or 2 years in Iowa about how important is it to offer health insurance. And 70% of all employers indicated it was very important. And another 18% said that it was somewhat important. And then the other 13%, which were really small groups, said it wasn't very important. The largest of employers in Iowa, 500 plus employees, well over 90% of them said it's very important. But I would say this about employer-based health insurance. What we know today could very well change due to the societal culture change over time. When we look at the millennials following the baby boomers, and the millennials, if they become more and more free agents with employers and they jump from one employer to another, at some point they may not want to be tied to any particular employer plan. We don't know if that will be happening anytime soon, but I do see that as a potential down the line.
If our taxes change.
Yes, if tax changes and political discussion and laws, and whether or not we're successful at controlling healthcare costs. At some point, I've always wondered, how long will it take employers to finally say, you know what, enough is enough. Why are we in the healthcare game? And yet employers are holding very, very steady with doing just that because they see this as a great advantage to attract and retain employees.
There have to be options out there that I think right now, I feel like you're leaving your employee out on the drive, right? And yet, I don't know what those options will be, and it's relatively new, so I wonder.
Well, I think part of it is, if I had to go pay for an individual policy, which is really expensive because of that risk pool, and have to use after-tax dollars,
Right.
it's really expensive.
Yeah, and if I'm a large employer, even a small employer, I'm looking at the viability of that market. And so if I do push my employees into that individual market, do they end up not showing up for work because they didn't get health insurance? So it can be a slippery slope.
Well, we're just about out of time, and I really
We have to
appreciate
end on a high note.
I know. I'm going to give you that opportunity, right? So one of the things we always like to do is end it on give you guys an opportunity to give your final thought and feedback. And then also, if you have something that might be an actionable thing, something businesses could do, or they could help influence either their own company, or and if they could, make Washington decide how to figure it out.
Yeah.
You said end on a high note.
Yeah. So, why don't we go ahead and start right here, and I'll give you a chance to start this off.
I just think that this whole industry is changing. It's continued to change for the last 5 years, and I see the next few years continuing to be an involvement, especially with the payer system. And employees are going to have to get more engaged in their health care. And again, the overall, health of our nation, I think is starting to get more of a focus, and that's really the only way we're ever going to control cost is to improve the health of our people.
So to make sure we end on a positive note, going back to something I think Ed said about just even access to care, we're really lucky to live in this state. We really do have compassionate providers that care a lot. We have some of the best care, so all you have to do is travel around, to different cities, walk into a hospital out in Washington, D.C., you will appreciate our healthcare system here in this state. Granted, do we have opportunity for improvement? Absolutely, we do. There's no doubt about it. But we're very fortunate. And so one thing that I would actually leave an employer with that they could actually do tomorrow, low cost or no cost, goes to the heart of what Lori just said, which is they can change their built environment for their employees tomorrow. So I still go in, even into my own offices, but I still go into a lot of employees' offices in other companies, and I see the opportunities that are presented to them to live an unhealthy lifestyle. So you can make changes, you can serve the right foods, you can, not put the donuts out, or the cupcakes, and you can make, taking the stairs a really inviting thing to do. You can change that environment, you can change your policies so that the temptation simply isn't there. And that's behavioral economics. That is nudging people into making good decisions because the healthy choice is the easy choice. So that's something they can do tomorrow, and the tools are out there in the public domain to figure out how to do it.
When we get down to the end with that, I'm going to actually come back one more time, so I need to spend one more time to think this time. But one question we always ask people is there something we didn't talk about today that we should have, or that we should be talking about? And then we'll turn off the camera and keep it hidden. So we'll come back down the line, so we'll start continuing.
I agree with everything that has been said, and really, it boils down to behaviors of employees, of employers, of the healthcare providers, of insurers, of the general public, and incentives drive behaviors. And what we need to do is figure out new ways to provide incentives that don't have the perverse byproducts of what we've had in the past when we incent the provider community to do what they do best, and then really get out of the way and allow them to do what we know that they can do. And I think also employers have really been on the sidelines for quite some time, and they have been cheerleading for cost, keeping costs reasonable, but I think they need to go beyond that and talk more about what are they getting in return. When we compare our country to other industrialized countries, the outcome or the care that we get may not be as great as we think it is based on other industrialized countries, and this is from the Commonwealth Fund. So I think we have improvement that can be made, and the positive note, and I'm trying to be positive, is that we can do it. I know we can do it, and actually just listening today with what's been happening here in Iowa, improvements are being made, and we just need to see it happen more and more, and frankly, quicker.
Providers, physicians are more engaged than ever. They're focused on the issues surrounding quality and improving the health of their patients, particularly those with chronic conditions, is consuming their thoughts right now in terms of what they can do themselves to get their patients to take ownership and to turn around and do something about bending that cost curve. It is a very common discussion when you go see a physician today, and particularly at the Iowa Clinic. I I would say that whenever I look ahead to the future, I don't think that drive for innovation is going to change. In order to do this in a meaningful way, innovation has to be a part of it. Adaptability and embracing the issue of adaptability. That's something that we talk about all the time, and I think a lot of other providers are doing the same thing. So, on a positive note, I think when the physicians grab hold of an issue and say we're going to take ownership of it, they don't let it go very easily, and I think they're going to tackle this problem with all the tenacity they need to do to be successful at it.
Just have to give them a grade, right?
There you go.
Publicize it.
I'll start down with you then, just to wrap us up. Something that we didn't talk about briefly that maybe would have been a good conversation for us, or something we could explore further in the future. Any thoughts?
Something that we can explore further. How can we collaborate together to engage employees in taking ownership of their health care?
I think that to me is the holy grail. And with that employee and with individuals in general having a voice and voicing, what is it that they want, what is so important, because again, I see them on the sideline at times, and when they are, there's a void, and it's being filled perhaps by something that may or may not be in their best interest. So I do think the health and welfare of the employees is really the holy grail. How do we get to that point? And maybe it's losing us.
Right, so I'll double up on what you said then. So it would, in a perfect world, it would be a really interesting approach to look at an employer and their employees, and not only get them engaged, but to your point, align the incentives. So if you could align the incentives all the way from the beginning to the end, because you talk to a lot of employees in other companies, and they have no idea why their premiums go up. They have no idea why they pay the rates they do, and they don't understand maybe they're part of a self-funded group and that they all contribute, and why you don't want to create competition per se, where it's, hey, don't go to the doctor. There has to be ways that we can do more with alignment of incentives.
Absolutely.
And I was going to say ownership also, but kind of a little bit different way is, I once had a client say, if you know the score, keep the score is going to improve. And if people just are aware of what their numbers are, they're going to take more of an interest in their health. So that way, I don't think this should be a topic, but also the political front, taking ownership and making yourself educated on what's happening.
Well, I want to thank you guys all for coming today. I really appreciate it. It was a good learning experience for us, and I know we'll have some good content. And of course, I want to thank the audience as well. Joe Gardiaz is our health and wellness reporter. Today's conversation spurred any thoughts or any story ideas. The best story ideas that we ever get always come from people that are out there running their business, that are experiencing these things. And those are the seeds for the topics that we can help share with the rest of the business community. So if you have something, you have an idea that you want to share, feel free to reach out to Joe. His contact information will be up on the screen. Again, I'm Chris Kineski, and thank you for being with us today. Thanks, guys. Appreciate it.
Thank you.
Thank you very much.